Thank you.
You don't think so?
I think it's a lot of bravado.
Do you? Oh, I don't. Well, they want to move to, I think it's almost half way, South Blue.
Yeah. Versus, yeah. That is a really tight space. Maybe I don't know about having the aerial. What's wrong?
Am I good? Hello, Brian. Can you hear me? Thank you.
The recessed Board of Directors meeting of December 15th is hereby reconvened and called to order. Will the Secretary please call the roll?
Director Bott? Oh, stepped away. Director Curry?
Present.
Vice Chair Deere?
Here is here.
Director Garza?
Present.
Director Harrington?
Present.
Director Ryder is absent. Director Robinson?
Present.
Director Sorrell?
Present.
Director Story is absent. Director Webster Cross?
Present.
And Chair Taylor.
Present.
You have a quorum.
Thank you. I'd like to entertain a motion to allow Director Webster Cross to remotely participate in this meeting as a voting member.
So moved. Second.
The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? The ayes have it. The motion carries. The next regular meeting of the board will be held on Friday, February 23rd at 9 a.m. The board meeting originally scheduled for January 26th is canceled, as we have included any items planned for that meeting on this reconvened agenda for the purposes of efficiency. The first item on today's agenda is employee recognition, which will be reviewed by Dr. Eric Kaitis. Thank you.
Thank you, Chair Taylor. Good morning, directors.
Great.
So we'll start with new hires. We want to welcome to the team LaWanda Anderson, Clinical Nurse Manager, Specialty Clinics Administration, Tanisha Brewer, Manager of Complex Care Coordination, Managed Care, Sharonda Cheeks, Nurse Coordinator 2, Peds ICU, Simi J. Joseph, Senior Director of Nursing Innovation and Research Programs with Nursing Administration, Erica Lester, Manager of Operations, Multi-Specialty Clinic, Pediatrics, Isaac Marufo, Community Engagement Manager, Department of Public Health, Patricia Pickens, Managed Care, Clinical Operations Manager, County Care, Allison Reynolds, Compliance Officer, County Care, Mark Sprinka, Chief Scientific Officer, Administration, Adewunmi Suleiman, Associate Manager of Respiratory Services, Pulmonary Medicine, Respiratory, Mark Wozni, Network Information Officer, Information Systems and Information Technology. And shifting to promotions, we'd like to congratulate Stephen Axe, who became our Chief Academic Affairs Officer with Administration, Daniel Arzit, Ambulatory Clinic Manager, Equity and Inclusion, Michael Hoffman, Associate Chair of Medicine, Hospital Medicine, Lori Kachich, Assistant Director of Public Health, Emergency Preparedness and Response, Public Health, Lisa Napsker, Director of Nursing, Professional Development and Education with Nursing, Shalise Roberts, Public Health Nurse 4, Public Health, John Rose, Senior Manager of Rehabilitation Services, Physical Therapy, Dawn Simmons, Medicaid Managed Care Ops Manager with Managed Care, and Ligi Vialil, Nurse Coordinator 2, Patient Care Services. We'll move to awards and recognitions, and we have a short video here of some of the pictures of our team that was here on site during that cold weather weekend with the snow and all the additional work that they did. We want to recognize and thank all of them. We had several people coming in on days off, people staying over, some who spent the night at the hospital so that they could be here for the following shift. So we greatly appreciate everyone who stepped up and supported the team. There we go. All right. Again, thank you to our team. All right. We'll go on to recognize our APP Fellowship accreditation. The APP Fellowship program at Cook County Health was awarded accreditation by the ANCC, American Nurses Credentialing Center. The prestigious recognition reflects the high standards and quality of CCH's APP Fellowship program, affirming our dedication to delivering exceptional education and fostering the development of competent and skilled APPs and commitment to meeting national standards. Of note, CCH's APP Fellowship program is the only one that's ANCC accredited in the city of Chicago. Wow. And we'll move to Food as Medicine. Very excited about this. CCH and CCDPH has participated with Commissioner Deere's Food as Medicine weekly health talks. There have been two, January 9th and the 16th. Dr. Hasbrook, Bettina Tassin, and Dr. Nicole Beltrucius-Hughes participated in the discussions on the importance of healthy food. And just a little bit of levity here. We want to celebrate our first baby born in 2024 at Cook County at Stroger. Moses was born at 9:39 a.m. on January 1st.
All right.
We congratulate his parents, Cosme and Marisol, and his big sister, Sandy. And then lastly, I don't know if we'll have time to go into the full presentation, but I did want to share the save the date at least about our Cook County Behavioral Health Summit. It is scheduled for February 15th. It will be held at the UIC, the Doran Forum. And we're very excited. We've had an incredible response already. I think north of 250 people have RSVP'd that they intend to participate. So it should be a really good discussion.
That's great.
Quick question.
We're going to hold this. Yeah.
When we have, people who stay over and give that extra, how are they recognized? Because they don't have to do it from what I gather, but they're doing it because they care.
Absolutely. Yeah.
So how can we demonstrate we acknowledge their caring? I'm just curious.
Yeah, so I think we are planning some, little recognition programs, right? Meals and coffee and that type of stuff. I can't speak to whether or not we're paying call pay overnight or anything like that. Gary, I don't know if we're not. Okay, so it's just out of the goodness of their heart that they're participating. Yeah, yeah. So, yeah. Sorry. Oh, we are going to do. Okay.
Can you keep us abreast of whatever programs you come to ask for those individuals? Because that's important. Thank you for bringing it up.
And employee incentives would be important for producing this happen, and you don't want people to be relied on being, well, they're the ones that always do it.
Absolutely. Yeah.
And sometimes incentivizing that makes it more.
Yeah. So nursing, HR, we're working with county leadership to figure out kind of incentives, emergency type pay. Yeah.
Great.
Thank you.
Thank you.
Dr. Nutter?
Yeah, Dr. Nutter.
Thank you. Good morning, directors, and
Good morning.
thank you, particularly given all that we have on the agenda this morning, for the chance just for a few minutes to talk about the work of the newly formed Office of Behavioral Health. Primarily, we'll focus today on the summit and the awarding of grants through the Impact Fund, but this slide just summarizes the projects that we're working on now. First and foremost, anytime you're embarking on a new project, first thing is to get the right people on the bus, and I think we're doing a good job of doing that. As of Tuesday, we have 8 of the 10 people from the Office of Behavioral Health administrative positions that will be filled.
And are they on board, or are they just?
Sorry, on board.
They're on board.
Onboarded, hoping that all 10 will be filled within the next 3 months or so, and even more so proud of the competence and character of the folks that we've brought on. So that, I think, bodes very well. We will skip over for today, talking about the community needs assessment, workforce assessment, and the opening of the new crisis triage and stabilization center at Providence. That's currently scheduled for August, so more to follow on that. We're obviously also assessing areas of weakness and strength within our system and following through on the recently awarded grants and projects through ARPA funding. So next slide. The summit was already mentioned. It is 4 weeks from today, February 15th, 8:30 registration, 9 o'clock for the event, goes through 5 o'clock. And that will be at the UIC Forum. As of, everyone here should have gotten save the dates. If you did not, please let me know. The invitations went out a week ago, and as of yesterday morning, we were at 330 registrants. So the idea of the summit is to bring together as many stakeholders in county mental health and SUD care as possible. So the idea is, to bring in folks from the state, from the county, from the city, from other municipalities, lots of community-based organizations, faith-based organizations, folks with lived expertise, clinicians, et cetera. Essentially, as wide an invite list, as broad a net as we can cast, and bringing those folks together for what we're calling a day of structured listening. There's very little being presented at the meeting, and much more time being spent taking in feedback. That's being done for 2 reasons. One is we want to get as much input as possible so that we have adequate guidance and, strategy for the awarding of the impact fund dollars. That will be through an open call on March the 6th. And the broader impact of the summit, we're hoping, will be informing strategic plans that will be countywide that can be used to address gaps, avoid redundancies, help us all to collectively advocate more effectively as a mental health systems, plural, throughout the county. We're also hopeful that this will be helpful in establishing the county's role as a leader, as a convener and a land bridge for community agencies for improving mental health and SUD care throughout the county.
Quick question for you.
Yes, go ahead.
Beat you. One just quick question. How were the potential stakeholders identified? I mean, besides clinicians, which are obvious, but how did you identify others to invite?
We had a list of we had a list from our consultants from the Kennedy Forum. We also had our internal list, largely drawn from CCDPH folks. So there are about, I want to say 800 or so on the initial list, but there's also on the invitation itself and on the save the date, there's an invitation to share with anyone. So the last list I think the next one that's going out will be about 1,300 folks that it goes to.
Okay.
That still doesn't necessarily mean that we're getting everybody that we want to. So if there are specific organizations or agencies that you want to make sure that that are included, please let us know or forward on. Don't feel like you need any permission from us to do so.
And is there some media attention, so radio stations, local neighborhood newspapers, that this has also been advertised in?
It's certainly been discussed in some recent public meetings. I'm assuming, Ms. Norrington is somewhere around here. I'm assuming that will be the case as we get closer to the summit, yes. Particularly
for those that may not necessarily either follow social media, but may also get their news from, say, their neighborhood paper like Austin Watch or a radio station.
Yes.
It would be really helpful to be able to have that information so that you have a broad swath of the population to be able to attend.
Yes. Yes. Thank you.
Okay, my question is, the team that you're pulling together, putting people on the bus, are you including any people who have any expertise in DBT? I'm quite sure you have CBT, but what about DBT?
This is a more broad kind of public health sort of perspective on that. I don't know that we have folks on the committee themselves that have DBT expertise. Certainly that we wouldn't be excluding folks with DBT expertise, and it's certainly an important skill to have.
Sure. The reason why I ask is because they do bring something very unique and different to the table. So,
yes.
Okay.
Yeah. And for everyone else's information, the dialectical behavior therapy is a type of therapy that is particularly used for folks who are chronically hospitalized and require extra clinical thoughtfulness, shall we say, and this is the best evidence-based strategy for that particular group of high-utilizing, quite vulnerable patients. So thank you for that, Director Robinson. Just a word on stewardship of funds. We have $74 million in ARPA funds, and most of that has not yet been obligated, but given the amount that's now in the impact fund that will be awarded post-summit, and the team we're putting together, we're quite confident that we'll be able to have all the funds obligated with plenty of time to spare before the December 31st, 2024 deadline. Next slide, please. So how will the funds be awarded? What guidance will we be getting for this process? As I mentioned, input from the summit and from related processes, for example, focus groups leading up to the summit, input from community partners, internal subject matter experts, the President's Office, input from other consultants that are working on other projects, specifically the workforce assessment and the community needs assessment that I mentioned earlier. And while the end product for the community needs assessment and workforce assessment groups is not due until the fall of 2024, they are not only making preliminary recommendations post-summit, but they've been working alongside folks at the Kennedy Forum and having regular meetings so that they don't have so that they can avoid redundancies in their own work assessing assessing needs. So next slide, please. Okay, so the impact fund will be, as I mentioned, awarded through an open call process that will begin March the 6th, and we should be able to evaluate applications, we're hoping, in early May. The final areas of focus for these grants has yet to be determined. This first list, the potential areas of focus, is essentially my biases going in. So that is subject to change. It includes opioid overdose prevention, gaps in the crisis care continuum, access to care, and really systems alignment, prevention strategies, upstream drivers, and development of new models of care in a manner that assures equitable access to historically under-resourced communities. Criteria for evaluation of grant proposals is still underway, but grants will certainly be assessed on the scope of potential benefit, whether or not and the extent to which they address gaps in care, particularly the populations that are currently most under-resourced, and whether the proposal has a path towards sustainability. We're well aware that equity doesn't happen by gravity, and as such, social vulnerability indices will be used in these formulas. And in addition to that, post the open call, there will be capacity building workshops on grant application, program design, and monitoring, so that agencies that may not have a well-developed grant machinery will not be at a competitive disadvantage. Lastly, this is the next slide, please. Sorry. This is the projected timeline, so that you can see that we're anticipating. Ideally, we would have been able to award the grants at the end of Mental Health Awareness Month in May. Given that we'll likely have about 300 or so grants coming in early May, the chances that we'll be able to get to that and do it in a fair way are dwindling, but we are confident we'll be able to do that in June, and so that all contracts can be signed, et cetera, as I said, in advance of the December 31st, 2024 deadline. So thank you for your time.
Thank you very much.
Mr. Chair, I want to say thank you to Dr. Nutter. I think you were quite modest in that the advisory committee that you all put together is probably one of the best that I've seen as far as a cross-section of diversity and discipline. And so I don't think enough can be said about that. And you all have created an energy around the Behavioral Health Summit. It's no wonder that you got over 300 already registered, and probably top 500 or 600 by the time that this is said and done. So thank you all for the groundwork that you have done. I know that it takes a lot of time and effort, and I know that sometimes, you know, people are quick to say what you're not doing right, but you are doing this right, and I just want to take an opportunity to say thank you. We're grateful.
Thank you, Dr. Dew.
Well said, Director Deere. Dr. Titus, anything else?
That concludes the report. Thank you.
Thank you very much. The next item is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted on the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual oral testimony or submitted written testimony?
We didn't receive any registrations, nor did we receive any written testimony.
Thank you. The next on the agenda are the board and committee reports, the minutes of the October 27th, 2023 board meeting, and the October 31st, 2023 special board meeting are presented for your approval. Are there any corrections or revisions needed to be made to the minutes? Hearing none, I'd like to entertain a motion to approve item 4A, the October 27th board meeting minutes.
So move. Second.
I'm not finished saying. We're gonna just do it all at once. And item 4B, the October 31st board meeting special minutes.
So move.
Second. Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye. Great. All opposed? The motion has been made and seconded. Is there, The motion carries. The ayes have it, the motion carries. I'm sorry. Next, Director Garza will now review the Human Resources Committee meeting minutes.
Thank you. The Human Resources Committee met on Thursday, November 17th at noon. The next regular meeting of the Human Resources Committee will be held on Thursday, February 15th at noon as well. We are not planning to have staff re-review the report from the meeting. If any additional questions are raised regarding the presentation and the metrics contained within the minutes, staff will be present and ready to address those. We did receive a report from the Chief Human Resources Officer, which is included within the minutes and included information on the following subjects: the FY 2023 Impact Summary and HR Activity Report on hiring, the FY 23 Impact Summary and HR Activity Report on turnover and separations, strategic initiatives that include talent pool, email campaign progress, nursing acceleration program update, the CCH Learning Institute, the HR Technology Roadmap, Q&A in the appendix. A request was made for statistics to be provided on the educational opportunities for nursing staff. Data will also be provided on the number of agency nurses that the organization has hired as staff. Recommended approval of proposed resolution in recognition of Israel Rocha Jr. There were no other action items presented for consideration, and the committee did not go into a closed meeting. If there are no further questions, the minutes are being presented for approval at this time. We do have a set of HR metrics included for today's meeting at the end of the agenda. Time permitting, we will review today, but if we are not able to do so, they will be included in the meeting record and posted to the website. That concludes my summary.
Do we have a motion?
So moved.
Second.
The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? The ayes have it, the motion carries. Thank you. Next, Director Harrington will now review the two sets of the Quality and Patient Safety Committee meeting minutes. Thank you, Director Harrington.
Thank you. The Quality and Patient Safety Committee met on Thursday, November 9th at 10:30 a.m. The meeting was abbreviated to only consider the action items presented for consideration. The reports expected to be reviewed were deferred to the December Quality Patient Safety meeting. The committee approved the following action items, which are included in the minutes. Item 4E, December 21st, 2023, Quality and Patient Safety minutes. The Quality and Patient Safety Committee met on Thursday, December 21st at 10:30 a.m. The committee received the following reports, which are included in the minutes. The High Reliability Organization Dashboard, follow-up regarding the data on patient experience, slides 2 and 3 of the HRO dashboard, and update will be provided in the future regarding what might have attributed to the score increase that occurred in March of 2023. A request regarding the information pertaining to 2024 Operational Excellence Planning, slides 23 to 28 of the HRO dashboard. It was requested that a roadmap be provided in the future on plans to achieve those goals. We received the regulatory and accreditation update. We also received an update from the High Reliability Organization Work Group. The request was made for future updates to include information regarding the strategies being employed to increase the scores of the measures of communication with nurses, communication with doctors, and hospital environment. Regarding the HCA HPS measures included, it was requested that future updates include a bar reflecting the scores from previous years. We also received an update from the HRO HEDIS Reach Work Group and received executive medical staff and medical executive committee reports. The committee received the Stroger Hospital and Providence Hospital Quality Committee summaries for informational purposes. The next meeting of the committee is Thursday, February 15th at 10:30 a.m. The committee approved the following action items which are included in the minutes. The January QPS Operational Excellence Dashboard metrics are included for today's meeting at the end of the agenda. Time permitting, we will review today, but if we are unable to do so, they will be included in the meeting record and posted to the website. On November 9th, the committee did not receive information in closed session. On December 21st, they did receive a report in closed session, but that is not expected to be reviewed today. So if there are no other questions on the minutes, both sets of minutes are being presented for the board's consideration at this time.
Do we have a motion?
I'll make the motion.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
Thank you. All opposed? The ayes have it. The motion carries. Thank you. The next item is a proposed resolution authorizing CCH to enter into a memorandum of understanding to create a corporation called Westside United NFP and approval of CCH becoming an initial member of said corporation. Shannon Andrews here?
Jeff is actually going to be.
Jeff is going to do it? Okay, got it. Jeff McCutcheon.
Thank you, Chair Taylor. Shannon is out today and she asked me to fill in.
Perfect. Thank you.
So back in 2018, the county joined with 5 other hospitals located on the west side to try to address social determinants of health. After collaborating for the last several years, it's been determined that we need to create a not-for-profit, which will be known as Westside United NFP. This resolution is the board giving approval for the county to be one of the members of this corporation, which will also include having a seat on their board of directors. We're asking for your approval.
Do you have any questions? Can we discuss? Thank you. Then I'd like to entertain a motion to approve item 5B, the proposed resolution authorizing CCH to enter into a memorandum of understanding to create a corporation called Westside United NFP and approval of CCH becoming an initial member of said corporation.
So moved.
Second.
The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
Aye. All opposed? Thank you. The next item is for the consideration of 3 proposed reappointments of Stroger Hospital Division chairs. They were originally planned to be placed on the January QPS agenda, but are being presented directly to the board for consideration. Dr. Claudia Fegan, jumping ahead, will review the item. Thank you.
Thank you, Chair. This is to streamline our process in that anyone who is coming up for reappointment who happens to be sitting in a chair position will be presented for renewal of their chair position at the same time as their reappointment. Dr. Thomas Ladd, who's served in a role as chair of the Division of Hematology Oncology for many years, is up for reappointment. We would seek to reappoint him to that role as the division chair. Dr. Paul Lamberti is the chair of the Division of Orthopedics. He's only been in this position as chair of Division of Orthopedics, but it is time for his reappointment to the medical staff, and so we would seek to reappoint him in that role. And Paul Malarkey, who we recruited here to do mammography, is up for reappointment. This is his first reappointment, and he would be reappointed as the chair of mammography at this time. I'd be happy to answer any questions. None of these individuals have any flags or concerns in their credentialing files.
Thank you, Dr. Fegan. Appreciate it. I'd like to entertain a motion to approve item 5C and the 3 proposed Stroger Hospital Division reappointments.
So moved.
Second. Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? The ayes have it, the motion carries. The next item is for the consideration of the Stroger Hospital and Provident Hospital medical staff appointments and reappointments and changes. They were originally planned to be placed on the January QPS agenda, but are being presented directly to the board for consideration and approval. Dr. Akintoran, President of Stroger Hospital Executive Medical Staff, and Dr. Paul Allegretti, President of the Provident Hospital Medical Executive Staff, are presenting these for the board's approval. Dr. Allegretti,
They were unable to attend because of time difference.
oh, well, Dr. Akintoran's here. They're here. And then who's gonna, please? Huh? Oh, they don't? Well, tell us who the people are.
So, just in case there's any question from.
All right, does anyone have any questions about the appointments, reappointments? They're here, so, to ask any questions. Thank you.
Thank you.
No questions? All right, perfect. I'd like to entertain the motion to approve item 5D, the proposed Stroger Hospital and Provident Hospital medical staff appointments, reappointments, and changes.
I'll make the motion.
Second.
Thank you. The motion has been made and seconded. Is there any discussion of the motion? All in favor?
Aye.
All opposed? Thank you. The ayes have it, the motion carries. The next item is the grant award-related items to be received and filed. They were originally planned to be placed on the January finance agenda, but are being presented directly to the board for consideration. Pamela Casera, our Chief Financial Officer, will review the item. Thank you.
Sure, thank you, Chair. So before you, as Debbie pulls it up, you will have your receive and file grant reward-related items. We have started to summarize them if we can make them a little bigger. Thanks, Debbie. At the top there, total $7.796 million. We have categorized them for you, $500,000 in amendments, $6 million in renewals, and one new award of $1.2 million. And the executive sponsors are here if there are any specific questions.
Any questions? You can see it there, but it's in your package that you received before. The question on the grant related items. Give them a second.
Hearing none? Thank you.
No, we're good. All good. Thank you, Pam. I'd like to entertain a motion to receive and file item 5E, the grant award-related items.
So moved.
Second.
Thank you. All in favor?
Aye.
All opposed? Thank you. Next, we'll go back to finance. Perfect. Next, Vice Chair Deere will review the Finance Committee meeting minutes.
Thank you so much, Mr. Chair. The Finance Committee met on Thursday, 11/9 at 9 a.m. The next meeting of the Finance Committee will be held on Thursday, February 15th, 2024 at 9 a.m. The committee considered the following action items, which are included in the minutes. Conditionally approved 39 contracts and procurement items. Approved the proposed real estate related matter. Request for approval to enter into a lease assignment with Howard Brown Health for medical office space located at 467 East 31st Street in Chicago, Illinois. Approved proposed real estate related matter. Request for approval to enter into a purchase agreement to acquire approximately 20,000 square foot industrial property located at 5325 South 9th Avenue in Countryside, Illinois. We approved two proposed resolutions authorizing the closure of bank accounts held by Cook County Department of Public Health with Bank of America and Fifth Third Bank, and we received and filed grant award-related items. The committee received the following reports, which are also included in the minutes. 2 emergency purchases were presented. The report of the September fiscal year 2023 financials. The fiscal year 2023 year-end preliminary financial update is included for today's meeting at the end of the agenda. Time permitting, we will review today, but if we aren't able to do so, it will be included in the meeting record and posted to the website. Regarding, January transmittals presented directly to the board for approval, the proposed contracts and procurement items total number are 32, and that is number 2, 6, 9, 10, 11, 12, 13, 16, 19, 20, 21, 23, 27, 30, and 31 are pending review by contract. And so we will move forward with those. Item number 1, we'll have Dr. Lamar Hasbrook.
Did Charles, would you like to come up as well? Thank you. Help guide us through.
Yes, please.
Good morning, Charles Jones, Chief Procurement Officer for Cook County Health. This morning we have before you, as Commissioner Deal said, 32 items. Of those 32 items, all 32 require responsive letters from the Office of Contract Compliance. We have 16 back and there's 16 in progress. So number 1 is Dr. Hasbrook.
Great. Morning, Chair Taylor and directors.
Morning.
Good morning. Lamar Hasbrook, Chief Operating Officer of Public Health. We have one for your consideration. It is a grant-funded contract to extend and increase for the fiscal impact of $54,000. The vendor is the University of Minnesota. It is to extend through June of this year. And essentially, they're doing a technical review, assessment, analysis, and a report on the workforce needs for the local public health department. So essentially, they'll be answering the question, what is the full complement of talent that we need to be a fully functioning local health department that meets the foundational public health services and capacities? They have done such a report. It's in draft form. It's been reviewed and sent back to them. So this is just some extra funds to go back and do the revisions and tighten it up and bring it to us. We are eager to share those findings with this board as well as the commissioners. It will answer the question in terms of the FTE complement and the fiscal impact of the FTE complement for our local health department. I can take any questions if there are any.
Thank you.
Thank you.
We look forward to hearing about it.
Request 2 through 8 is clinical with Dr. Fegan.
Good morning, directors. The first contract is for a contract with the University of Illinois to provide coverage for our urogyne services in the form of 2 clinic sessions a week. We lost our urogynecologist a few years back and have not yet been able to recruit one. This will provide our patients with access to that care on an ongoing basis and continuity until we're able to hire a urogynecologist. I'd be happy to answer any questions about that. The next contract is with the Northwestern University Feinberg School of Medicine, and this is a part of a grant-funded program called Primary Care Training and Enhancement, Community Prevention, and Maternal Health. Participants in this program receive a Master's of Public Health from the Northwestern University as a part of the program. The next contract is to provide assistance for us. We have only one maternal fetal medicine physician, and this allows us to provide maternal fetal medicine services throughout the health system. We are also trying to recruit a maternal fetal medicine physician in addition to the one we have. It is a very small community in this country, and there are not enough of these doctors to provide the services. Half of all of the deliveries that occur at Stroger Hospital are high-risk pregnancies, and so we have a great need for this service to provide it to our pregnant patients throughout the system.
Do we have some plans in the way for recruiting for both of those, or a way to look at trying to garner the? Yeah, well, yeah, we're attempting to recruit. As
particularly for maternal fetal medicine. It is a very, small community, of docs. They all know each other, and it's really convincing someone, to come here. The last person we had who fulfilled this, left the area, and so it's trying to get someone else who will come into the area. And it's a very, busy service for us, as I said, a number of patients that we provide.
That in combination with the Eurogyne is so important for the maternal health issues that we're seeing.
Yes, it is,
Helpful
yes.
that, might look at some targeted ways to try to help to bring someone then in-house.
Well, the board approved, last year, and we have now a, recruiting services, so we'll see whether, that yields us any, benefit in some of the areas that we are thin.
Great, look forward to hearing how that's going.
I'm sorry, question.
Yes, sir.
You said half of the pregnancies?
Yeah, just about half of them are high risk. We don't do that many deliveries here. I mean, if you can compare to what we did 20 years ago, the number of deliveries we do now, as a result, it's skewed at Stroger, and so, yeah, just about 50% are high-risk pregnancies. And add to that, we've had a large influx of migrants who could come in and deliver, about 250 in the past year, and many of them have not had prenatal care, and by definition, someone who comes in to deliver without prenatal care is a high-risk pregnancy.
So if we remove that 250, how does the number look? And I know you don't have the numbers in front of you, so I'm not asking you.
But it's still high, it's still high. We've always had a high. We have a high number of patients who will come here to deliver who have not had continuous prenatal care.
I'm just curious, do they have insurance, the ones that we're talking about that are high risk?
Yes, a good number of them do. A good number of them do. So that has to do with, for example, women who are it's not their first pregnancy and thinking that they know what they need to know and choosing not to have prenatal care.
And I guess my question is, can you reiterate how we are looking to mitigate that? I'm sorry. This is just absolutely, I was trying not to ask that question, but,
We do make, effort to provide those services at all of our outlying clinics so that, patients don't have to come to Stroger campus to receive prenatal care. There have been changes in the last, 15 years in, our workforce and the services we provide, but we do try to make women aware. We have family medicine taking a bigger share of that burden and trying to help women understand how important prenatal care is. But this is not limited to Cook County Health as an issue. But
it's a national issue. I'm very aware of that.
Yeah. But we do have a lot of folks who come in and have not had prenatal care.
well, and I guess the reality is, to your point, Dr. Fegan, this is a national issue. It's about Black maternal health. And it is huge across the country. It's an issue that we have discussed largely at NACO and looking to figure out ways to mitigate that with a multiple county effort. So Houston has a huge issue there. Detroit has a huge issue. We have the issue, and we found that it's nationwide. So that's what prompted my question, because obviously Cook County is the second largest.
Right. So I don't think that Cook County can mitigate it alone. There had to be a national campaign talking about the importance and of prenatal care and the impact it has.
As well as stepped up prevention efforts.
You know, so I think that the March of Dimes puts a fair amount of effort into this, but it's not something that, you know, we try to make it as accessible as possible, but you know, people have to avail themselves of the services available.
So if I can add the Westside United discussion that just happened, we've talked with Rush. We've had some preliminary discussions around population health initiatives, this being one of the primary focuses, because we know it is such a burning platform that needs attention. But, you know, from a pop health standpoint, and how do we pool resources, better coordinate more locally? To your point, it is a, you know, multi-county national issue, but care starts locally, right? So how do we better coordinate with our community partners?
Sorry, I must have missed the Westside.
Yeah, Yusuf, yeah.
Sorry.
and perhaps this is something at some point at QPS we could just talk about at some point, right?
Yes.
Recognize this is finance, so let's go to the next contract.
Okay. I lost my, the next contract is for, peritoneal dialysis. So peritoneal dialysis is an alternative. Most people are familiar with hemodialysis. We're happy to be able to provide this service, for our patients. It allows patients to do dialysis at home. The vendor provides the supplies for, these patients and assists in, some of the instruction that these patients require to perform this, dialysis at home. And so these patients are able to, for example, give themselves dialysis in the evening and then go about their daily habits or go to work during the daytime. So it is a program. These provide the supplies for them.
Dr. Fegan, I'd just like to ask, how are we seeing trends in the use of the patients more open and willing to use
Yeah,
this
so
type
it's a growing program. We previously didn't have it available, but in the last 5 years, it's a growing program that we're trying to increase the number of patients. So it's a small group right now, but as we talk to more patients and try to get them to accept a different approach to this, it's growing in our community. It has not traditionally been had great inroads into the African American or even the Latinx community.
I'm sorry, Dr. Fegan, going back to the pregnancy, is it possible that we can actually get a cost analysis? Let's see how much it's costing us to treat those women who have those high-risk pregnancies. You may not be the person that because I think if we look at the numbers, this may become a more urgent matter for us.
We can think, yeah, we'll get some consideration back from Kai this
Well,
week.
absolutely, yeah, we'll forward.
50%, I'm floored. And
Yeah,
not to mention that we're talking about lives, this is 50%. I had no imagination or nightmare that it would be that high.
Yeah, Director Robinson, we'll pull a more comprehensive report together specific to maternal health for you.
Thank you.
Okay, so the next contract is sleep disorders. Yeah, for our patients who have sleep disorders, this provides them with the CPAP and BiPAP equipment that's non-invasive equipment that allows them to maintain their airways overnight. This vendor provides the equipment as well as the instruction for the patients on the proper use and treatment of the equipment. The next contract is for telemetry. This is for telemetry services provided at Providence Hospital to allow us to increase our capacity for telemetry services as we're increasing the census of patients at Providence, as well as taking care of more complicated patients. So this will allow us to extend those services. The next contract is for software that we use. The directors should know that a certain percentage of all of the films that are read or studies that are read within our system are blind reread by another provider. This peer review allows us to ensure the quality of the films that are done, and so that it allows us to ensure that there's agreement between two different providers reading the same study. It's a quality control software for us.
Thank you.
For equity inclusion, with, Ms. Andrews, I will, present in her absence. 9 and 11 actually is for language service, so they are similar in nature, but, going with request number 9, we're asking you to extend and increase the contract with, voice for telephonic interpret and, document translation services. This is for the Department, again, of Language Services. It's a 4-month extension. The vendor provide remote language interpreting services by video remote and voice-only interpretation. This request will give us additional time for the completion of the procurement process, awarding and implementing of a new contract that is going to give us consolidated services, implementation and transitioning to that new vendor. Request 10, to extend and increase the contract with Superior Health Linens, doing business as Angelica. This is our laundry and management services, for the Department of Materials Management, $7.2 million for a 12-month extension. Vendor would continue to do laundry and linen management services at Stroger, Provident, and Core. And, this would also allow time for our RFP in the second quarter of this fiscal year.
Charles, I have a question, just totally related. Like, how is laundry and linen in equity and inclusion? Like, just curious.
Because the Department of Materials Management report up to Ms. Andrews.
Okay, all right, thank you. Just curious.
And then lastly, language service again, which is Syracom International. This is telephonic interpretation documents, translation services, extending and increasing that contract as well for $534,000. So, again, this request will allow the additional time for that consolidation that I spoke about with request number 9, from putting video remote and telephonic all together with one vendor, going into implementation and transitioning altogether.
So just a question, some of the address with some of these types of services, just like Belly says, there's probably a wealth of these types of services more locally being provided. I just want to ask in general, do we have local agencies or companies bidding on these contracts for us here? Because my knowledge is that there are several right here close by.
You mean language services, right, for example?
Yeah.
Yes.
And
linen laundry is local, right?
Yes, sir. We do. And the new contract that was approved by the board a few months ago that we're transitioning to is more locally, plus they have MWB participation from the local area for the service.
And we've already procured that one?
Yes.
It sounds like it says. Yeah, do we know what outfit that is? Is that somebody local living
Yes.
from Chicago?
Yes.
Okay.
Okay, thank you.
Thank you, Charles.
Good question, George.
All right, request 12 through 16 is finance with Ms. Caceres.
Good morning again. Pam Caceres, Chief Financial Officer. We have 5 items before you this morning, all rev cycle items, which are to, again, continue the good work we've started over the last 2 years on the revenue cycle turnaround. This first one is Salud Revenue Partners. This is a request to increase the contract. Salud was awarded an RFP contract. They are an underpayment recovery service that comes along behind on account for their zero balance, and that makes sure that we were paid per contract, whether Medicare, Medicaid, or commercial. It is a contingency contract, and it has been asked the ROI on this contract. So we spend about a $6.5 million annual spend with recoveries of $38.7 million, or a 500% return in 2023.
I think that's a good return.
That is a good return.
Well, 2 things with this one. They're about 1,000 miles closer, so I'm happy to see. As we continue to pursue a local contract. And as we discussed the other day, going forward on these contingency contracts that are tied to contingencies, we will get during revenue cycle reports the performance level of these companies. And
yes, I've actually spoke to Chief Revenue Officer Curtis Haley about coming back to the board and presenting sort of an overview on the progress of the whole turnaround and the ROI.
Thank you.
Next contract is for Council for Affordable Quality Healthcare, also known as CAQH. This is extend and increase request. CAQH was awarded sole source because it is a proprietary software that we use to credential our providers with the payers. 3-year extension through January 2027, not to exceed $120,000. Next item is for our armored car service, Davis Bancorp. This is also an extend and increased request. This was awarded sole source simply because it was the only carrier that could meet our all-risk insurance requirement. This is a request to extend 36 months through 12/31/27 in the amount of $85,600. Next item, System Innovators of Chicago. This is an extend and increased request. This is a software also awarded sole source because it was proprietary software for point of service collections at the clinics. This is just a request to extend for 12 months while we do go out for RFP. Software such as this is really not proprietary anymore. There are several vendors that offer this sort of thing, so this is just to extend while we go through that process. And the last one is Cedars, yes, Cedars Business Services. This is a new contract awarded through RFP. This is a one-year contract with 2 one-year renewals. This is an international accounts receivable collection service. And so believe it or not, Cook County is a destination healthcare provider, and we do get quite a few people coming from out of the country just to get healthcare and then go back home. And so, again, this is a new contract. We will see how successful they are for 1 year, and if there is success, then we'll continue to renew. Happy to answer any other questions.
Thank you very much, Kathy.
Request 17 HIS, Ms. O'Banion.
Good morning.
Good morning.
Morning. Angela O'Banion, Chief Information Officer. This request is for our Luma text messaging service that we use to send patient reminders about various appointments, monkeypox, COVID, other regularly scheduled appointments. This was acquired during COVID, largest COVID impact, and that's why it's an emergency purchase. There are multiple products that we have since purchased via RFP that will provide this service, and we are planning to replace this product with one of those referral scheduling products that we have recently, the contracts have recently been awarded.
Okay, request 18, Human Resource, Ms. Palmer Vogt.
Good morning, Carrie Primack Vogt, Interim Chief Human Resource Officer. This request is to extend our contract with Slalom Service, the services related to our HR optimization and recruitment optimization programs that we've been doing for over a year with that team. An RFP was issued earlier this month. That RFP had been initially thought to go out last fall. It did not. We've now put it out, but we're going to need to bridge those services, and so we've decreased and minimized the support that they would need to provide for continued support of our SharePoint, our dashboards, particularly our executive dashboards that have been put together, our job tracker, and some of our document intelligent management systems that were put in place as well. These are services that are resources that CCH does not have in any of its departments, and so we've asked for an extension through June 30th to ensure time to get through the RFP and implementation of the RFP selection. Any questions?
And you said what's the timing for the RFP responses? Just curious.
I don't remember the exact date. It's in February.
And we post for at least 30 days.
Thank you. Okay.
Request 19 through 30, Operation and Development, Mr. Williams.
Good morning.
Good morning.
First contract is for a Safe Haven Foundation. It's an extend contract with no fiscal impact. It's a 12-month contract period, 11/1/23 to 10/31/24. And this is to continue services for snow removal across our health system. Anchor Mechanical is an extended increased contract for $3,132,000. It's a 12-month contract, 12/1/23 through 11/30/24. Anchor provides monthly maintenance services for the refrigeration and ventilation equipment of Stroger, including replacement and identified commonly used parts and equipment on that mechanical systems. Johnson Controls is an extended increased contract for $1.5 million. It's a 12-month contract, 12/1/23 to 11/30/24, and they provide testing, maintenance, repair services for our security systems, building automation, two-way radio systems, and electrical distribution equipment. We are looking actually system-wide at a strategy to do an RFP in FY24, and we'll likely break out security and building automation.
No, good.
MedSpeed LLC is an extended increased contract for $1,168,989. It's a 12-month contract, 12/1/23 to 11/30/24. And this vendor provides courier services for patient sample supplies and reports from Providence, Cermak, and all our outlying clinics to get samples back to the lab here at Georgia for processing. Metropolitan One is an extended increased contract for $720,000. We're asking for a 6-month extension from 1/1/24 to 6/31/24, so we can post an RFP. And this is for continued valet parking services here at the central campus.
June 30th for the end date.
June 30th?
Oh, sorry about that. Yep, my bad. Maybe it's a leap year. Legal Aid Chicago is an extended increased contract for $311,217. 12-month contract period, 1/1/24 through 12/31/24. And Legal Aid provides legal services to our population, including public benefits, family law, housing, immigration law, employment. And they've had consistently good performance, and we've been able to expand the services to the inpatient teams. Matthew Madison is an extended increased contract totaling $105,300. It's a 12-month contract period, 1/1/24 through 12/31/24. And they provide operational data program design support for our case management information services. Helena Labs is an extended increased contract for $79,374, 12-month contract period, 1/1/24 through 12/31/24. And they supply all technical assistance, software upgrades, and support for 2 of our instruments within the hematology and immunology division of the lab. ATI Vandenberg Ambulance is an execute contract for $3.6 million. It's a 36-month contract period, 2/1/24 through 1/31/27. And they provide ambulance transportation services for patients to and from CCH medical facilities. And there's a 1-year renewal option included in this contract. Abbott Labs is an execute contract for $1,945,000. It's a 36-month contract period, 2/1/24 through 1/31/27. And they provide our iStat equipment, cartridges, and reagents for point-of-care testing at all of our facilities. Medline Industries is an execute contract for $597,100. This is for a capital purchase, and this is to replace all of our public-facing defibrillators across Stroger and the Providence Hospital campuses. And the last one I have is Cardinal Health. It's an execute contract for $378,723. It's a 60-month contract period, 2/1/24 through 1/31/29. And this is to lease equipment, maintenance of that equipment, and reagents to perform TB culture testing at the Stroger microbiology and virology departments.
Thank you. Thank you.
Okay, final 2 at 31 and 32, Soldier Hospital, Ms. Austin Kathy.
Good morning, Chair Taylor and directors.
Good morning. Good morning.
Donica Austin Kathy, Chief Hospital Executive for Johnny Stroger Jr. Before us, we have the execute contract for Waystar, a pharmacy prescription claims processing service. This contract period is 12/1/2024 through 1/31/27 in the amount of $1,683,000. This vendor was selected via an RFP process, and this is for prescription claim processing service. They will provide prescription claim processing services for CCH ambulatory pharmacies, including checking patient eligibility, processing prescription claims for outpatients who have been identified for self-pay, rebilling claims, et cetera. Questions? The next one before you is an execute contract for Aretamed in the amount of $224,000. One-time capital purchase. This is for 2 MRI monitoring systems and accessories. These are used for our critical care patients as well as our anesthesia monitoring. Question?
No question.
Okay, thank you.
Contract. Thank you very much, Charles. I appreciate it. Thank you much. I'd like to do 2 motions, one for the minutes and then one for the items, finance items first. I'd like to entertain a motion to approve item 4F, the November 9th minutes of the Finance Committee meeting, which contain the following action items: approval of the contracts and procurement items, receiving and filing of the grant award-related items, approval of the request to enter into a lease assignment with Howard Brown Health for the medical office space located at 467 East 31st Street in Chicago, Illinois, approval of the request to enter into a purchase agreement to acquire approximately 20,250 square foot industrial property located at 5325 South 9th Avenue in Countryside, situated on a 1.55 acre site. It's good to know. And approval of 2 proposed resolutions authorizing the closure of bank accounts held by CCDPH with Bank of America and Fifth Third Bank. So with all of your items.
I'll make a motion.
Second. Thank you. The motion has been made and seconded. Is there any discussion on the motion?
Chair Taylor,
Yes.
please record me as voting present on request number 2 of contract and procurement items contained within the Finance Committee meeting minutes.
So noted. Any other questions or discussion?
Please vote me present,
That's my next item.
And Chair Taylor, myself as well, around the item contained within item 4F for those same committee meeting minutes.
Thank you. So noted. All in favor? Aye. With the noted presence. All opposed? Thank you. The ayes have it. The motion carries. The chair would also like to recognize the attendance of Director Bott for the meeting. Thank you. Next, because of today's reconvened board meeting, the Finance Committee meeting originally scheduled for today was canceled, right? And all planned January Finance Committee action items were placed directly on this agenda and reviewed with Director Harrington and Charles. Therefore, I'd like to entertain a motion to approve request numbers 1 through 32 under item 5A, the contracts and procurement items subject to completion by contract compliance.
So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the items? Thank you. All in favor?
Aye.
All opposed? The ayes have it. The motion carries. Thank you. Here, get it through today's agenda. The next item is my report. I'd just like to note that the 2024 calendar of meetings and of the board and its committees was released for publication on December 15th. So all should have it and in your calendars. We also received the report from the interim CEO for informational purposes on December 15th, so we won't be reviewing that today. Those documents are also included in the meeting record and are posted publicly to the website. Because we have a meeting of the search committee scheduled right after this meeting, due to time constraints, we might not get through review of all of the informational reports under item 8 at today's meeting. We'll start with the review of the financial report by Pam Casera and see if we'll have time to get through all the reports before adjourning at 11:50. By the way, all the reports will be included in the meeting record and posted publicly on the website. If any directors have questions on the reports that we didn't get to review today, please let Deb know, and she'll facilitate a response to your questions. So mindful of that. After the meeting, the managed care metrics are not planned to be reviewed today. Those were already posted on the website on December 15th, and that committee will be reviewing fresh data, a fresh set of metrics tomorrow, actually. Thank you. So Pam, we'll start with you.
Sure.
Pam, I just need 1 minute.
Sure, Debbie.
Problem with the file, just 1 minute.
I'm happy to review the year-end preliminary financials because it is a good news story.
Well, we look forward to that.
Yeah, right. And the year on a good note.
And everyone, thank you. I'm mindful of your time and your patience. Remember, we're combining 2 meetings into one, so
That's right.
we have a lot. Thank you. So thanks in advance. Well, into this now.
Okay.
Thank you, Debbie. You can go to the next slide. So no surprises, as we've pretty much been reporting all year. We ended the year favorable, $362.1 million on an accrual basis and $252 million on a cash basis. The reasons we've been talking about all year, on the hospital and clinic side, we had volumes that were better than budgeted, and then on the county care side, we had membership that was better than budgeted, which resulted in favorable financial performance. County care did end the year unfavorable to their budget. However, as we'll see on the next slide, if you want to go, Debbie, there's a lot of year-end work that is still underway with the year-end financials. We keep the books open almost all the way through the audit period and until the final audit comes out in May to be able to properly record anything that needs to be recorded to the fiscal year end. The big ones there are the ones in the light blue there, the ones that come from the county, the pension and other post-employment benefits, real estate, tax allocation, true-ups, and any allocated county costs. And so we're usually waiting for those pieces before we can put this final stamp of pencils down, we're done. But as you can see there, total revenue is almost $1 billion better than budget. Again, due to the volumes, both at county care and the clinics and the hospital. And the expense side, $500 million worse than budget. You can see that medical claims expense line there is the primary driver, again, due to the higher than budgeted county care membership. So $362 million better than budget. Yay.
Yay.
I'll pause.
Yeah, I mean, directors, we say it lightly, but we like think about the fiscal condition that we're in and the way we're operating fiscal discipline now versus over the past. So very, very noted. And really, by the way, appreciate the hard work of everybody.
Mm-hmm.
Yeah, that's done that.
Next slide, Debbie. So quickly, and again, just looking at the volumes, right, very strong on the inpatient side, as we've been talking about, almost over 30 more patients per day at Stroger than budgeted. Almost at their budget at Provident, but, you know, almost 3 times as much as 2 years ago and twice as much as a year ago. So again, moving in the right direction. Primary care and specialty care visits combined, the ECHN practices are ahead of their budget as well. Primary care, again, lagged behind because maybe an overly aggressive budget. We had planned for some new primary care providers to be hired, which did not happen, but we still were able to come in ahead of budget. And then the county care membership, of course, due to the pause on redetermination that didn't start until mid-year. Next slide.
Do we have any update on what, I'm sorry, this is HR probably, the primary care provider hiring, how that's going? Do we just end it going?
I do not,
We'll come back.
Carrie wants to give an update or come back at another time and give an update.
Thank you.
Next slide. So again, these are just the volume trends over time. You can again see that little dip in 2020 related to the pandemic, and then everything is pretty much rebounded. Next slide. The payer mix. So we did end on a high note. You can see the Medicaid, the highest it's been over the last several years, and the uncompensated, the lowest it's been over the last several years. But as we know, that's due to the pause on redetermination and the expansion for the health benefits for immigrant Americans and seniors. But on the right-hand side there, you can see that in the last few months, we have started to see minute decreases in Medicaid and upticks in uncompensated. And so we'll continue to monitor that and report back over the course of this year. We're 6 months through the redetermination process, so we're halfway through now. And in addition, the health benefit, the immigrants will be coming on the county care rolls, so that'll help offset some of the folks we lose through redetermination. Next slide. RevCycle. So, you know, I've been reporting and bragging on RevCycle all year. Unfortunately, they ended the year with some of their metrics in the yellow, but that was primarily driven by Medicaid payment processing issue that the state had with their system, so no fault of RevCycle. They were falsely denying claims for eligibility. This was resolved in December, but of course that's the new fiscal year, so unfortunately at the end of the year they were slightly off target on their metrics. Next slide. Denials. Again, you know, here are the messages they continue to work on, they continue to trend down, trying to eliminate the underlying reasons for them happening in the first place. They are meeting the metric in the upper right box there to be the industry benchmark of less than 2% of cash collections, pretty much for the last year and a half, 2 years, consistently. And then the quarterly, the government denials, since we're so high Medicare and Medicaid, that graph at the bottom right, they're also trending down and almost next to nothing. You can see where we started in the second quarter of 21, and what a huge decrease, and then sort of leveling out after that. Next slide. This slide just again depicts beyond the traditional charity care and bad debt that the county, CCH provides to the county and community, but the others, all the other services, CERMAC and public health, that we provide as well in terms of revenues and costs, and illustrates again that we're pretty consistent across years in terms of dollars and percent. Next slide. Savings initiative. So we did hit our mark. We budgeted $47.5 million in impact savings or revenue enhancements. We came in at almost 48.9, so 103%. You see a few yellows there that lagged a little bit behind target. However, some of the greens offset that, and we still came in at 103%. And then county care, of course, the story is the graph at the bottom, budgeted the blue bars to slowly tick down. The membership actually continued to increase all the way up through July, and then you start to see the small decreases. Aaron is not with us today, or maybe he's on the phone, but they've actually seen a lower fall off of membership than what they had originally thought as well. And again, that $81 million loss is preliminary and is primarily due to some year-end adjustments related to the actuary estimates, right, of the incurred but not received claims, as well as the risk adjustment I think we talked about last month related to the HIV patients, yeah, and how they sort of downgraded those. And so they're getting less revenue on that book of business.
Do we have at some point, maybe in the managed care meeting, to talk about the impact of that as
Yes.
we anticipate what that will be next year?
Yeah, Aaron can speak to that, and I think in the managed care meeting, that would be. Mm-hmm. Aaron, anything you want to add?
Yeah, good morning, and sorry for not being with you in person this morning. Yes, we're still in discussion around the impact of that. We, on an annual basis, around 35 to 40 million impact. So
you say 35 to 40 million? I believe we broke up there. Is that what you said?
Yes, that's correct. So we are still, and we hope to have some that over the next month to 2 months.
Director Curry.
Aaron, Director Curry, I know we talked about, profitability success and how those discussions are going. It sounds like they're still moving in a positive way, that some of this will be offset or reconciled in a favorable to the plan.
Yes, I would still describe us as cautiously optimistic based on our conversations to date.
Thank you. Thank you for the question. We are all cautiously hopeful. Because 35 to 40 million is a significant number. Directed by.
Yeah. So I know there's discussion about growing the volume of folks on the plan. Are there other revenue generating discussions to offset some of the impact financially? terms of collaborations or other services?
Yes, there's a number of different both cost savings and revenue increase initiatives, and certainly happy to talk through those more in detail at the Managed Care Committee. But both on the revenue side, beyond there's a number of risk adjustment opportunities. There's also on the cost savings side, a number of priorities that we're putting around populations, including ESRD members, CKD, for example, but happy to go into that in more detail.
Yeah, that'd be at another time.
Okay, yeah, I think that's one of the things Director Curry and Aaron are handling in the Managed Care Committee. That'd be one item to look at. Director Garza.
This could be something that could be deferred to that meeting, but I'll put it on the table anyway. So Aaron, what planning has been happening in preparation for the RFP on MCO plans that should be coming out in the next few months?
Yes, so we have actually been doing quite a bit of work around that. We have started with just looking at the past RFP cycles, and we've actually prepared a first and now a second round draft of an RFP response based on information that was in those past RFP requests, as well as some things that we know are very likely to be included in this next round. So I think are really well positioned for that. We'll be bringing on some consulting help to assist us with that over the next month as well. And then, of course, once the RFP drops, we'll be doing a lot of work to then adjust our response to fit with the specific requirements.
Okay, thank you. I had a chance to look at the 2022 quality metrics, and I noticed that the plan fared really well in comparison to the other plans. So I would think that would help make it more competitive for the county.
Very much so.
Any other questions?
No.
Would like to give you some kudos. I actually saw the NPR report showing statewide across the U.S. the Medicaid recertification. It was good to see that Illinois had the highest rate of recertification, so that less than 11% of folks had dropped off.
Yes.
So good work on the work that you're doing to get folks recertified. Are there other activities that you're looking to try to even bring that under 10%?
Well, anybody that crosses our doorstep that has lost their coverage, we do hook them up with our financial counselors and help them to re-sign up. The health plan is a little more limited, but they are having multiple, what did you call them, Aaron? Activities actually out in the communities, so that, again, we can reach those people and again, get them re-signed up. So.
It was nice to see Illinois #1 for a positive.
More positive.
So, great work on that.
Yeah, so yeah, good work to Pam and Aaron, appreciate it. And Pam, thank you for starting our year off with a positive financial report. Thank you. Next, we'll have the QPS Operational Excellence Dashboard presented by Raji Thomas. Do I see Raji Thomas? There she is. Perfect. Okay. Behind the lectern.
Good morning, everyone.
Good morning. Good morning.
All right, Debbie. As we are presenting the first, set of data points this year, we just want to bring to your attention that we are making a few different changes to the way you would see the data. In 2023, we used to present on monthly increments. However, in 2024, we would try to show you overall, rolling 12 months data to give, a broader, stroke on how well the metrics are performing. All right.
Hi, quick, can you remind, who's the group, how those goals were, the goals, numbers were defined?
Certainly. So the baseline data were, as you see there, it was based on the 2022 to 2023 performance. And some of us, we go through the slides, I would explain in detail too. Some of those baselines were from 2022 performance and some were based on our 2023 performance, based on when those work groups were established. So the goal that you see would be what it would require us to get to 4-star, CMS 4-star rating. The stretch goals would, if CMS holds the same measures, we strongly believe that they would get us to get to CMS 5-star rating.
Thank you.
Okay, thank you. Right, so we will go to the next slide. I am a little, I wasn't sure if I would be presenting today, so I didn't come all prepared. I'm going to just, share that up front. All right.
You're doing great.
Okay, thank you, appreciate that. All right, so patient experience work group. We will continue to monitor nursing domain top score for 2022 as well. That will remain as one of our goals. As you can see here, the control stats were taken from July of 2022 through June of 2023. And, the rolling 12s were established based on our data from January of 23 through December of 23. So this will remain as one of our goals because we do see some opportunity here to continue to work on. And we do believe that improving that score would help us get to or move us closer to the 4-star rating as well as 5-star rating. Next slide, please. This is a new measure we are introducing this year, survey response rate for age gap survey by receive date. As we had shared with the board in the past, this is an area where we saw a significant decrease or, responses from patients, related to our Prescani scores have been going down. So this will be a focus for both Providence and Georgia this year. We have some specific tactics that we have identified, in relation to some of the challenges we have. As we had shared with the board in the past, we realized that if patients who get admitted through ED are discharged from an inpatient area, they tend to get 2 surveys from us. We believe that does have an impact on the overall volume. We are also working to improve how we accurately capture patient addresses and contact information. The clinical leadership is also, adding additional patient rounding to make sure that patients have we have correct patient addresses, as we send out these surveys. Next slide, please. All right. This is also a new area of focus for this year. As you can see, when we analyze the data for CLABSI for 2023, we realized there is an opportunity for us to work on this. Definitely as a, hospital-acquired condition, this will be, a focus for us. This will also help us get to 0 patient harm as we are able to bring this number down. So we are forming a new subgroup that will look at different ways to address this concern. And we have multidisciplinary engagement around this issue. We have nursing, infection control, and physician leaders at the table to help us, come up with specific strategies to bring CLABSIs down. Next slide, please. We don't have the December data, so it's annualized data. This will remain, COTI will remain as a focus area for us, as we understand that these numbers would have, huge impact on our CMS and Leapfrog scoring information. So there is a subgroup being established to specifically work on COTI prevention and COTI reduction. So we will be bringing more data as we, as we are able to, demonstrate the improvements we will be making as part of those efforts. Next slide, please. All right. This was one of our goals that we were focusing on last year. However, we barely met our target in 2023. So we will continue to, focus on this effort, serious reduction for 2024 as well. We again have a subgroup that's working on specific strategies for Providence and Stroger. We have a multidisciplinary team with representation from nursing, infection control, and physicians. Next slide, please. Periop, pulmonary embolism and DVT is something that has really high weight on our PSI 90 composite as well as CMS size and leapfrog safety grade. So this will be a major focus for us this year, and we hope to bring some impressive data to you in the near months. We are establishing a VTE subgroup as well as we are implementing VTE advisor to help us with optimizing, the use of, the data capture by our physicians. All right, we'll move on to the next slide. So all cause readmissions, including readmissions as well. This is going to remain as a major focus area for us for this work group because, they have a number of strategies they have in mind or they are currently starting to implement that we strongly believe will impact this data. The team is working on developing an algorithm for clinical decisions, and they're also, planning on education sessions on, helping our providers know how to use that tool, to ensure that correct data is being collected.
Right, Roger, quick question. I mean, with the work groups, and I think this is just blanket. Can you maybe give insight to how the work groups are composed, like examples of participation in the work groups, whose members are?
Perfect. Yes. Each work group has an executive sponsor who would be somebody in the C-suite. And then work groups are led by dyads. So there is a physician and a nurse leader or an operational leader assigned to those work groups. Under each work group, then there are multidisciplinary team members who are identified based on their expertise, the goal we have, or established for that group, as well as, the different, the kind of, the history that they have with the organization. Like, the strategies for Providence might not be, applicable here. So, we look at, the goals we have as well as the tactics we are, implementing, and then we decide the makeup of that work group.
Thank you.
One question. You mentioned that you're looking at the algorithm to help with clinical decisions. So I'm left to believe that there's believed to be a reason for the readmissions?
Yes, that algorithm would proactively identify us, help us identify patients at high risk for readmission. And, we have talked about bringing probably AI into that discussion or that, but our goal is to get to a place that would, stratify our patients for, high risk for admission so we can be more proactive and we can help with the care coordination, with clinic appointments and other additional services that might help with the readmission.
It's a clinical tool that's built into the EMR that actually looks at objective points within the chart that would indicate that this patient may be higher risk than another patient for readmission, right? So historical utilization, certain comorbidities, those types of things. So it would flag, Mr. Jones might be a little bit more risky, so direct your care managers there versus, Mrs. Smith, who is much lower risk for being readmitted.
Sure, I understand.
Yeah.
The next question comes, because once you identify that, then the next question will be, how do you get to some of those things that are not captured in that, such as with your risk assessment? And they're going to be things that your nurses are going to gather, understanding that the individuals are not able to refill prescriptions. How do you address those issues? That's the next level down, and getting to the problem.
Right, that is correct. We have certainly discussed.
Well, I was just going to say care management teams, as they engage with the patients, especially the ones that are flagged as higher risk, they'll do kind of a deeper level assessment in terms of, any insecurity, social risk factors, food insecurity, inability to get meds.
So we have, interdisciplinary daily rounds that occur for each patient, each patient that's admitted on the inpatient side. So that's where these kind of discussions occur. We discuss about, potential risk for readmissions, their needs, post-discharge, and, all those points are taken into consideration as we stratify the patient for, his higher needs.
Everything sounds great. The one piece I didn't hear is where, because I can tell you anything when I'm in front of you, but when I get home and I don't remember what the discharge planner told me, or I don't think that I can afford my medication, are you gonna have anyone who follows up? Because if you're really trying to get this number, that's where the rubber meets the road.
I hope Dr. Mikhail, it's okay for me to give the preview. We did have recent, communications or collaborative conversations with Rush, who has an at-home visit. It's not home health. It's basically your proactive home visits to make sure high-risk patients have that type of support. Once they go home, they realize they have a new concern or new challenge that they were not aware of when they were in the hospital. We are in a very early discussions, but we do realize that there is opportunity for us to work with community organizations as well as our neighboring hospitals to, broaden that the service, the repertoire of services that we provide.
Fantastic. You sound like you're on top of it. I can't wait to hear the results.
As I said, it's really early discussions that we are having, but we are very hopeful that there is more collaborative partnership we can have with other organizations in the neighboring area.
Thank you for the charts. They are very helpful. They are quite easy to follow.
Thank you. Thank you for making me feel at ease right now. You have no idea when Dr. Mikhail texted me like 10 minutes ago saying that you're going, and I'm like, all right, got it. All right. Next slide, please. All right, geometric length of stay, so an increase in recent months. So the work group will remain focused on this. They are focusing on inpatient length of stay and our which we believe would, help us decrease the overall length of stay. There are a few specific areas that the workforce is working on. We are, working on. I would go into the details on next few slides, but we are looking at reducing the turnaround times for imaging studies, including X-rays. And also we are, this particular work group is working with readmissions work group on palliative care, early intervention for patients with serious illnesses as well. As Dr.
I'm just curious, you probably covered this in GPS. Why was October such a big spike?
We had talked about it, but I can't recall the exact reason. There was some variation in the movement of people through various care settings.
Right. Yeah, I know post-acute care, besides kind of going home, has been a challenge for us in terms of having, skilled nursing access, skilled nursing facility access, inpatient rehab access. Oftentimes we do kind of single case agreements to facilitate that transfer. A lot of that can take a little bit of time, right, to kind of move that through. We do have a good proportion of patients needing post-acute care. Less than ideally, they sometimes end up going home, which is not, we're trying to do the right thing for the patients. And then a lot of the throughput things that you're going to see in the next few slides, we think internally are opportunities that we can kind of work through, radiology turnaround times, consults, those types of things to kind of facilitate faster dispositioning of the patients. But those post-acute things are kind of a bigger work that we're going to have to look at.
Along with the new MOU with Westside United, which
Exactly.
has
That was a very timely resolution.
Follow-up services active for high utilizers as well.
Exactly. Yeah.
Yes. Now we all know why you did that, right? All the reasons. There are various reasons of why we need to have that garbage.
Was this slide a setup?
You did more than you thought.
To answer your question, Dr. Taylor, we have drilled down on the October data, and we know exactly where we saw those, that increase. We know we had increase with sepsis, newborn, vaginal delivery, and acute leukemia areas that led to that spike that you see in October. But the task force is drilling down further into that data to see if there are any specific measures that need to be taken to bring that number down. So we are hoping next month we come to you, that number would definitely be down. Right. Next slide. For the throughput work group, there is a new metric that's being introduced. As I mentioned on the last slide, we are going to be tracking the turnaround time for our radiologic studies because we believe that currently the data shows that it takes around 13 hours for us to get the X-ray taken and read. And, 57% of most of our inpatient tests are, diagnostic radiology related too. So we are hoping that by being very strategic about reducing the radiology turnaround time, we would be able to reduce the, the inpatient length of stay as well. All right, we will move on to the next slide. The case mix index will continue to be monitored and worked on this year. As I mentioned last month, we are starting with a CDI inpatient in-house program, which we hope with additional physician oversight, we will be able to influence this number positively. Next slide, please. Surgical CMI, again, this will remain as one of our focus areas for this year. As I bring data next month and moving forward, we'll be able to show you the variations. But right now, the teams are focusing on establishing their baselines and their stretch goals for 2024. Next slide, please. Monthly CMI, this remains as one of our major efforts for this year. The subgroup is working on deploying, as I mentioned, in-house CDI program, which we believe would, impact both medical and surgical and overall, CMI for Georgia. We will move on to the next slide, which would have the Provident data. I'm going to pause on that slide for a little bit, so just so the directors have an opportunity to look at the goals we have set for 2024 as well as our stretch goals. Again, we are hoping we identify these goals based on their weight towards, getting us to CMS 4 stars and 5 stars. And we have also taken into consideration, the cross-section of those measures that would have an impact on leapfrog as well. All right, next slide, please. Here we have 12-month rolling information. We are, not still at our goal, so we will continue to focus on this. Nursing domain, as I mentioned earlier, has a really high weightage considering the CMS and leapfrog scoring, methodology. So that will remain as a focus for both Georgia and Providence. Next slide, please. For both Provident and Georgia, survey response rate will be a new measure that we will start monitoring. Provident has, historically struggled with getting enough responses back, which would have, the number that would have statistical significance. So that is going to be a focus for this year. Hand hygiene compliance rate. Oh, next slide, please. Thank you. As you can see here, we know this is an area where we have some opportunity for improvement, and we understand the significance of focusing on improving the compliance rate. So for Provident, the clinical outcomes team has identified hand hygiene complaints as their area to focus on. Next slide, please. All right. As we mentioned in our presentation last month, we are going to be mimicking the strategies we found successful at Georgia at Provident in 2024. So it's cross-pollination of best practices between our two campuses. We know we have some opportunity there. Next slide, please. All right, left without being seen remains a concern for Provident. So again, this is something we will be focusing on next month. When I present, I would have better data that shows our performance since we started monitoring it. Can we go to the next slide, please? Thank you. Here is the list of goals and baseline as well as stretch goals for the measures we have identified identified for ACHM to focus on in 2024. Next slide. All right. So ambulatory HEDIS work group will continue to focus on the hypertension patient cohorts. As we mentioned in our last presentation, the team, have identified very specific goals around getting the number of registries in these cohorts, improved. So we are hoping that with, working specifically and strategically, tactically with that group, we would be able to improve this goal. Next slide, please. All right. This is, again, a measure we will continue to monitor. The team has identified some new registries that we can be part of. So this effort will continue this year. We recently moved the ambulatory patient experience under the ambulatory quality experience, quality work. So we plan on moving to an official CAP survey for ambulatory in 2025. That's pretty awesome. That's really a stretch strategy for us to get patient feedback from ambulatory areas. So, but we know that's a stretch goal, but we are ready for it. All right. We also will be focusing on. Oh, can we go to the next slide, please? The provider explanation of problems and conditions. As you can see, we are on an upward trajectory, but we want to continue to work on that, knowing that we do serve a unique patient population that would have unique needs, as we explain, that disease conditions and follow-ups and everything. That will remain as our focus for 2024. This is next slide, please. This is a new measure we are introducing this year, and we know this is going to be pretty challenging for us to get to our goal and stretch goal, but we know that the registration staff has such a huge influence. They are the face of the organization as our patients come into the clinic. So this is a new measure. We are certain that working on this measure will help us improve the overall rating on how well our patients would recommend CCH. So next slide. I think that's the end of my presentation.
Thank you. Very good presentation. I did have one question on the cervical cancer screening. Are the metrics you're looking at identified? You said eligible. That said completed screening for eligible, right? Qualified rather. Is that the percentage looking at those who have been identified as qualified, those that are offered, those that are accepted? It'd be good to know, right? Once we identify them, did we offer the services? Did they accept it, right? Because, right?
Yeah. Dr. Mikhailis, can I turn it over to you?
In the denominator for inclusion into the measure.
Yeah.
So that is the percent of people who are included in the denominator and then who
offered.
Complete. Yeah. Well, so there's a step between identified and offered, right? So it's whoever is based on the data is expected to be screened, right? So that may or may not include offered, right? There's a step there where the provider or the office team has to realize that that patient is in the measure,
right,
and then offer it, right?
Yeah. So I think that'd be to the point. It'd be good to know who's offered.
Sure.
Okay.
Right. To track. We'll have to think about how we get to that, but yeah.
That's right, because we would want people accidentally dropped from the cracks because they're
Of
not
course,
actually
yeah,
off of that.
and that one's a tricky one too, based on the findings and then the follow-up, which I'm sure you're aware, right? There's different timings, much like colonoscopy, right? So.
Yeah, I was curious.
We will definitely look into that and, look to bring that data back next time.
Dr. Robinson, you have a question. I can see it in your face.
I was listening to the answer.
Right.
And I'm thinking about, what does that denominator include again?
So it's anybody who's identified as eligible in the measure, right? So.
Goes by the guidelines.
Exactly, yeah, there's a guideline. We can bring the definition, specific definition.
Yes, yeah, it'd be good. I had the same question. I think it's something for us to delve into QPS, because I think if we don't track that interim step, the final.
Right. And this is an issue where you can prevent, there's a big impact if you can get to it early.
Right.
So I also, the question about all of these measures, what are the ones you prioritize, significant effort or resource towards, because of the impact it has on outcomes and both cost, as well.
Is this the at-home version?
Oh, no, so this is for cervical cancer.
Yeah,
Right, so it requires like a pap smear.
Okay. I'm trying to figure out how we can, if it has such a huge impact, that's not my area, so I don't know. But how do you capture the people?
I mean, it's a HEDIS measure, and in the ambulatory environment should be happening, but and when people are admitted, is there a workflow, ER admitted, that, also flags people?
Back in the beginning.
Well, that's the key piece I heard mentioned, where it says, if they know. That if they know part is gigantic.
Yeah.
Because
well, and
they're not
patient
knowing,
accepts too.
we can't afford for them not to know, so we can't exclude them just because they don't know. If we don't measure, then we can't manage.
Well, yeah, I think that's what she was saying, like, there's a big training here at the admission staff.
Yeah.
Big, I mean, that's what we think about. I'm not telling you how to do your job, but I guess I know. You hear the questions.
And I don't know that ED inpatient that we have a workflow for that, so that's an interesting idea, to flag people.
And then regarding your courtesy of registration staff and really trying to have that positive forward face, and basically rebuilding trust with the healthcare system, what types of incentives, training are you building in for those initial key clerical type staff, in helping them to have that empowerment of feeling that they're also bringing people into the healthcare environment?
So this is a new measure that the work group has identified, so they haven't gotten to the point of identifying the tactics. So can I bring it back next month with more details, with very specific tactics that they are developing as part of, their efforts to increase that number. So right now, what they have done so far is really collect the data, analyze the data, and identify this as an opportunity or area for us to focus on. I don't think the work group is yet to the point of coming up with specific tactics. Dr. Mikaitis, keep me honest here.
Yeah, so we can bring back, the last slide indicates A3s are being developed, right? So that'll be kind of the specific interventions that the teams say. It'll be some component of, Ling engaging the team with, CI care training and that type of stuff too.
And now that you have your baseline, you can look at what de-escalation, formal engagement, the new health equity lots that was published this past year in terms of re-engaging people with trust for the healthcare system. It'll be good to hear what you're doing for that.
We'll be sure to bring those tactics back, yeah.
Thank you.
Are you possibly suggesting there's a leaderboard for those clinical staff to really give an incentive?
That certainly would be a likelihood, but you have to also set up what the parameters will be for their education, and then what you want to have the outcomes with, so that you actually know what your targets and what the metrics that you're going to be measuring with based on those objective trainings that you're providing. But certainly that will be an excellent point, because that first point of contact is why, unfortunately, 51% of persons who have those first medical encounters don't have those second medical encounters, because of the person they see at the door and meet at the door.
Exactly. I was actually telling Dr. Mikaitis earlier today, on my way here, I ended up helping two patients get to a clinic. Both of them had, language issues, language barriers. And I felt like if I wasn't there helping them, they probably would be lost for a really long time. And we did interact with some front desk folks too. But as I was walking back here, I was wondering, like, if, with that language barrier that they have, if they would have been able to get the help that they needed, unless the front desk folks are really, sensitive to their needs, and she said, like, health equity and all those things, so, yeah.
And those types of behaviors are what we're really not only wanting to capture, encourage, and then incentivize the utilization of, because that will factor into this metric you're monitoring.
In terms of incentivization, I'm not sure if Ling is here. She does an excellent job of recognizing people who go above and beyond. And we have a program here where anybody can recognize, one of the CI care values, and then we go out, senior leadership would go out and recognize, just so we can we can positively augment that behavior.
Yeah, so there's the Commitment to Excellence Award, which I know you've all heard about. We're looking to kind of expand that to be a little more kind of an on-the-spot recognition program. So when you see a positive behavior, there's immediate reinforcement from, you know, a leader who's rounding, the clinic manager or whatever, but there's, you know, a way that we can kind of immediately give kudos for the behaviors that we want and hope to see, right?
That's it. Thank you, Brad.
Thank
You did a
you.
great job.
Thank you.
We appreciate it. Next, we'll have the HR metrics with Carrie Primick Vogt. Carrie, you're gonna do a great job too.
No pressure. Hard to follow that act. Good morning again.
Morning.
I had to think about that to make sure it wasn't afternoon yet.
Not quite.
Carrie Primick Vogt, Interim Chief Human Resource Officer. Okay, so before you, the first couple of slides are the FY23 year in review. So although in November you got most of the year's data, this gives you the last several weeks of that fiscal year. So it goes December 1st, 2022 through November 30th, 2023. Our total filled positions were 1,359 with 853 of those being external hires, so not internal or promotional transfers within the organization. And as you can see in the graph on the far bottom right, the overall time to fill did have that upward trajectory, and we ended the fiscal year on November 30th with a 97-day time to fill once all the data was in and calculated. Our goal for time to fill is 90, so we're a little bit off, and of course you are well aware of all of the different recruitment initiatives that we had done throughout 2023, and we're hoping those translate into 2024, continuing to bring down that time to fill, but we are also cautious through Q1 of 2024 because of the amount of data that is usually identified that can look a little bit skewed. So you'll see at the end of my presentation, the last slide about the 2024 data for December. We do not give the time to fill because it's only 30 days worth of data, and the number is off because of when the recruitment process has started. Any questions about this? Okay, next slide. This is our separations for FY23, and as you can see, we had overall fewer separations, and I cannot wait to tell you about the December data because I'm very excited about it when it comes to separations. But overall, 2023 was lower, and on one of the next slides, you'll see that we are still below the national average on our separations and turnover rates. Final quarter, we ended with 103 separations in Q4, which is definitely down compared to years past. And when we looked at month over month, we anticipated that November, and then you'll see in December, we expected the numbers to go higher, and they did not this year. So we were very pleased that our retention and recruitment efforts were, our retention efforts, not recruitment efforts, our retention efforts seem to be and appear to be working. And as we dive into the data fully and analyze last year's data, we'll see what those triggers that were working for us so that we can expand upon those this year. Next slide. So here's our turnover rate year over year since 2018 and that national benchmark for 2023. The national benchmark is a 22.7 turnover rate. We are at 9.8 for fiscal year 2023. So we're very pleased that we are so far below the national average on that, and we will continue to mark that trajectory, and hopefully it will continue to go down. We were at 11%-ish over the last couple of years through COVID, which everybody had gone up, and we were no exception to that. However, we did come back down in 2023, and we will be putting in more programs to ensure that that maintains or continues to go down. Any questions on FY23? Okay. Our next slide and last slide is our FY24 data, which is the 31 days in December. We filled 99 positions, and most, if not all of that recruitment activity did happen in 2023, but the results came in December of 2024. And we filled 44, so just on about 40%, a little over 40% of those were external hires, and really chipping away at that vacancy rate total in the organization, which we're very pleased. And we had a 72% acceptance rate during the month of December as well. Any questions about that? All right. This is the exciting slide for me. If you'll see, FY24 shows that in the month of December, we only had 87 separations, and it is historically a high separation month for us with the retirements. When we compared looking at just the month of December for the last 4 years, every year but this year, or this past December, we were at 100 or more resignations, and so to be at 87, we were very pleased to see that that retention number was really continuing into this FY24 year, and we hope that that continues.
I'm sorry, you said resignations and retirements? Or just
Sorry, resignations and retirements, all separations are left.
all
Yeah.
separations were-
Yes, as a matter of
Do you
fact,
have a split? It's curious, I mean, Director President, there, I can ask you, perfect, no, never mind, yep.
retirements, we
why?
had 67, yeah.
Yeah, that's the major question.
We know why.
I'm waiting on the why.
So why,
What are your thoughts on why?
on why there were fewer retirements?
Yeah.
We are hopeful that it's because of our retention efforts, our increased learning and development opportunities, the retention bonus. We are still, that was initiated this past year for the first time. We have to analyze that data now that we've seen it. We've gone through that first full year of utilizing that retention bonus, which was issued in June and December, July and December timeframes for the staff for the last year. And then there is another group where the retention bonus trickled into this year. However, we're going to be analyzing that data and reporting out in the next, hopefully the next report, that, and we'll see what that impact was. But we anticipate that there will be an impact because of the retention bonus as well.
So does retention bonus mean what I think it means? How do you define retention bonus?
So we issued after impact bargaining with specific classifications where we saw high turnover rates and knew that there was a huge impact because of the Great Resignation and COVID, to incentivize them to not leave our organization. And so they received bonuses this year at 6-month increments to retain them. So they basically were receiving their bonus 6 months after the first 6 months of retention, and then they received an additional bolus after another 6 months of retention.
I love it. Thank you for sharing that. I think certainly I'm looking forward to you all analyzing the data. That is phenomenal. Thanks for sharing.
Well, it'd be good to understand, like, the retirements who are eligible who didn't take it, right, at some point?
Yeah.
That's probably a cliff that's built in over time.
I want to add something, and I hope I don't light a fuse on it.
Yeah, you're
but-
about to light a fuse.
Okay, a study was just released this morning, in terms of retention bonuses. And Palomar Health System, which is a large system, you may have seen this.
I have, yes.
And you saw the number associated with their retention bonuses, and we're nowhere near there. And it sounds like you're getting some positive results.
We are, and we're actually, these next couple of days, today and tomorrow, crunching those numbers as we speak. So, and so we will hopefully see where we compare.
It's dark, but these were six-figure retention bonuses, $100,000 that they offered to nurses in Palomar. New nurses coming on, flat out $100,000, and existing nurses, $100,000 paid out over 3 years.
So we understand our challenges.
Yeah.
Just to be clear.
Illustrate
Just
that.
to illustrate our challenges, which is why we're a great place to work. That's
Yeah, you're the best.
the best.
Yeah, our retention bonuses were not that high.
Right. Director Garza.
Thank you. Kara, I'd be interested to know what the cost savings is in that reduction in separations between this quarter and last year at this time, and then 2 years ago at this time. Taking into consideration the opportunity costs.
Right.
So the cost it takes HR to fill the positions at that level, and then the cost of having those vacancies, period.
Yeah.
Might be some other elements that I want to consider, but I'd really like to see that next month, I guess.
Are you trying to say that may give fodder to increase that number to what Director Curry is talking about?
I'm not ready to commit to that. But I will speculate that I think it's a greater savings than what we're putting out there as incentive bonuses, I guess.
I'd be willing to bet that that's what the data will show us, yeah.
I think someone gave a number once about what the cost is of vacancies.
We did at one point. We go back and look at that. But, and then just, that'd be good to come back in the HR committee.
Yeah.
And broaden the board. I mean, you asked a question, but the broad, it'd be good to know.
Well, yeah, well, and I think it's gonna vary depending on
Roles.
the roles and the compensation and, so I don't know, it's not a straight line calculation, I don't think. I think you have hard data here that you can show that comparison.
Absolutely. Any other questions? Okay, I believe that concludes my report.
No, yes, one more slide.
Oh, one more slide. Oh, yes, the nursing accelerated hires.
Yeah,
We
that's
can't
neat.
forget our pilot program. Yes, our pilot program does end February 6th, so that is coming up. And so we plan on doing a lot of data analysis as soon as we've hit that end mark of the pilot program. But as of January 8th, so this does cross over quarter 4 from last year and quarter 1 from this year, we had 338 offers go out with 190 accepted, and our acceptance rate was 60%. Now, preliminarily, the data is showing us that the 40% decline rate does come from the fact that we utilized existing ranked lists for candidates that had actually already gone through interviewing processes, and those were not just-in-time interviewing and processing along with this accelerated process. It was in conjunction with previous processes that had happened even as early as the summer and last spring. So they were candidates that were, a little bit more stale compared to what the goal of the accelerated nursing hiring was, which is the efficiency and speed of doing immediate offers.
So if you really want to see the impact of the program, that part needs to be separated.
Yes,
Right.
and we are doing that, yes.
Okay, okay.
Mhm.
So, thank you. Dr. Peters, just curious, not to put you on the spot, how do you feel about, yeah, it actually puts you on the spot. Whenever you say not to do, you always like what you're doing. But just curious, like, in conjunction with this, how do you feel about this program, where we are, the nursing coming through, the progress made, is your, please, whatever you'd like to share.
Thank you for asking. Actually, due to this program, we have the highest number of nurses we onboarded for the last 3 months compared to the last 4 years, or since, I started here at Cook County. So that is great, and in fact, I think my nursing update is coming. I do meet with all the new nurses quarterly. Yesterday, we had to get extra chairs and rooms to really meet and greet them. So I think this is a great program. We are going to evaluate the outcome by separating what happened. We are also doing a survey with the nurses who joined through this process, the managers, and also HR teams. So hopefully we'll have that presented to the board next month, because I think this is an exciting time. And one of the nurses yesterday who joined made the comment, I am so glad that the Cook County is looking at the nurse rather than individually. We are making decisions through an interview process. So there are positive, feedbacks. From a manager side, that's a new process. They were nervous, but I think I'm also hearing some positive outcomes. So we changed the whole nursing orientation process to accommodate this. So more to come on that, but I'm excited.
Thank you, thank you. I mean, all the things we were talking about, in terms of the processes, onboarding, et cetera, improving quality, all of this starts with now actually we have a new group that we actually could train from the very beginning about in our club. So thank you. We're excited. And also board, I mean, think about for the last 3 years, this has been a topic of we hadn't gotten there. We actually are making very positive progress. So,
I think it'll be also interesting to see now the list of onboard staff nursing versus those percentage of agency nursing.
Right.
To see that we're now starting to make the turn in that as well too.
Yep,
So that's a very key indicator for the onboard nurse.
Definitely, we have that. Plus, we are also doing a trajectory on the agency cost declination based on the onboarding. So it's a combination of both. So we'll share that information.
Looking forward to see it.
Yeah.
I just want to say congrats on the out-of-the-box thinking. This, I think that's fantastic, so thank you.
And I think there's some others that report should be passed on too, right?
Indeed.
Very much so.
Indeed.
Very good. Fantastic work. You guys, since I've been here, you've been doing absolutely bang-up work. I know my questions may not seem like it, but I think you're doing fantastic work.
Why would I say?
The essence of greatness is to be pushed forward, right?
Yeah, exactly.
If I don't push you forward, then I need to leave.
There you go.
Well, then we'd just be plain bored.
There you go. Thank you. We appreciate both of you. Thank you. Appreciate both of you. All right. We have Directors, I'd like to remind you that we will actually be having our search committee meeting convening, of the board, all invited, at 12 noon. That said, for today, for this meeting, the board will not be going into closed session. So if there are no other questions or matters to discuss, we can adjourn. If you have any questions, can't leave yet, or matters to discuss? Others? Thank you.
Mr. Chair, I just want to say thank you to this body, because I think, you know, I want to highlight, I know I stepped out of the room, but the resolution for West Side United, I think, is game changing. It is important that we have a hospital and a system without walls, and I think we accomplished that by bringing in the voice of the community. So I just want to say thank you, thank you, thank you. I think this is probably one of the best moves since this hospital has been in existence, creating a formal partnership with the community, because it is the community that compelled us to be what we are. So thank you all.
I agree, 100%. And by the way, as we start to hear, thank you to all the staff. I mean, we appreciate it. We're giving positive comments, but we want to know that we recognize this is hard work, and we know that you're working really hard to serve Cook County and all of our communities. So we really, really appreciate it. So I want to say thank you. All right. As the agenda has exhausted, the chair declares this meeting adjourned. Thank you. You have found time to see you for those who are staying. Some of you have to. Yep, take a break. You got 45 minutes. She's about to take you out. You got 45 minutes. You got 45 minutes. The search committee